We're now live, Chair.
Thank you very much, Kirsty, and thank you for your help and enjoy the rest of your holiday.
Thank you.
Okay, I think we've got everyone here. So, good evening, ladies and gentlemen, and welcome to the Adults Health and Social Care Scrutiny Board on the 21st of October 2021. Welcome everyone who's attending. We are streaming on YouTube, so anyone watching out there, you're most welcome to do so, and hope you get something out of this for yourselves. The nights are getting colder, it's getting darker, so it's one advantage of doing Zoom meetings at home when it's nice and warm. So there we go. So thank you everyone for coming. Thank you guests. A special mention to Diane Chapman, who's come back to help us out for a short period. She'll be doing clerking. She's absolutely excellent. So it's really, really good to have her back. So welcome back, Diane, officially. Let's get on with the rest of the meeting. So she was nominated for the meeting in absence for apologies. We've had none for this.
No, not received any today, Chair.
Fabulous. So everyone welcome. So item number 2, members' interest.
Sorry, Chair, before we go on, Councillor Fenton Glynn doesn't have the Zoom codes. I've sent them on, so he will try and join as soon as he can.
Indeed. Thank you, Councillor Barnes, for that. Members' interest, to remind members to declare any possible interest they have at the time. Admissions to the public, it's not recommended the public be excluded. As mentioned, you're more than welcome to watch on YouTube. So item number 4, we've got 2 sets of minutes to approve. One on the 19th of October, and the last one, which was the 16th of September. Can I take those as a true record? Okay, thank you, Councillor Hutchinson. Can I have someone to second those? Thank you, Councillor Barnes, and everyone in favour of those. Just show your hands. Excellent, marvellous. Item number 5, adult services and wellbeing complaints and compliments. Ian, do you want to lead on this?
Sorry, Chair. I think actually it's a very misleading report in the sense that it's not a report from the Director of Adults. It's actually a report that comes from the Director of Public Services, because complaints and compliments report is compiled independently of the Directorate. So I think Richard Noble will probably lead on this, if that's okay.
Of course it is. Welcome, Richard. Thank you for coming and attending tonight. So if you'd like to give us anything additional that you want to add to the report.
Yeah, good evening. Thank you. So yeah, I'm here tonight with Lynn Hagan. We deal with the complaints. So we've compiled the adults report for 2021. So it's all been circulated, and quite a positive report. Obviously there was some people going over the COVID period, so there was quite an impact on our timescales, but we believe that we've put things in place moving forward to and I think that's starting to be shown. So if you've got any questions, we're happy to answer.
Fantastic. And tonight we're using the reaction button at the top to raise your hands. If you do that, I can take you in order. So I guess it's straight to questions, members, really. Is anyone indicating to any questions so far? I'm sure you do. Okay. So I'm sure you're not going to get off this lightly, Richard. You don't normally do. I've seen someone's hands. Councillor Hutchinson, thank you.
Thank you, Chair. I just wanted to comment that I found this report much more informative than the 2 previous ones that we'd read. It had the examples that it gave of the type of complaints that had been received fleshed it out much better than simply the numbers and the response times. So thank you very much for that.
Thank you.
Excellent. Thank you, Councillor Hutchinson. Councillor Barnes, and then we have Helen Hunter.
Thank you, Chair. Firstly, I think I'd like to thank Councillor Hutchinson for stealing my thunder again. in regard to the report. I think yes, I think I've made it commented in previous meetings and previous times, and I think maybe later on tonight might be the same old about the nature of the reports and sometimes how they're not that user friendly. The only thing I was going to comment upon, and whilst I appreciate that the number of the number of complaints were down, is how easy really is it to compare, particularly with regard to what's happened over the last 18 months, 20 months? How easy is it for us to really compare like for like or year with year in that sense? So, I suppose if it was 29 complaints against 100 initial inquiries and 29 complaints, whereas the previous year was 2,000 inquiries and 38 complaints, the numbers as an absolute look great, but so it's really just that comparison, particularly due to the pandemic, and we have to state that. So, Richard, I don't know whether you can answer that.
Richard, would you like to come back on that? Yeah.
All right. Yeah, I mean, well, as a number of complaints, we only physically record complaints that come through for investigation. So previously, I think we were on 38. So last year was a decrease of about 8 or 9 complaints. So as for service numbers coming in, this is just what's landed on the complaints team, and not actually where the service may have received inquiries.
Yeah, so it's very difficult, therefore, to do. So the absolute numbers are down. Yeah, that's fine. But I suppose what I'm coming at is there a mechanism that we can start looking at this more in relation to the number of complaints to, as you said, the number of inquiries that are coming in, to see whether or not the relationship is that way. Is that really quite a difficult thing to do?
At the moment, yeah, but we're currently implementing a new system where everything will come through this system to start with. So we're going to look at it. It involves you guys from the first stage, people who contact the service, contacting customer first. Everything will be logged through this system. So moving forward, we'll be able to dictate how many contacts we've actually had rather than just physical events.
Lynn, do you want to come back on that as well? You've raised your hand.
Yeah, if I could do. I've just joined Calderdale in August this year, so you're going to have to forgive me that I don't know councillors present. And I'm managing the complaints and compliments team. And I think coming back on the response of how we can do year-on-year comparisons, obviously we record a 5-year span, so we can measure it in that context. But with the exception of COVID over the last 18 months and the way that people have submitted comments and complaints, I don't think we're going to see a true picture for any service area realistically until we go into the next year or two and look at how that is. And one of the things that I'm keen to measure, because we're currently developing a new complaints handling system we hope to have in for the start of sort of March this year, is we get some more intelligent reporting. And we can look at how, because this service area is complex, such as we have, with other service areas, the key dependencies where we link into third-party providers as well, and how that relationship works and how their time constraints impact on our service, being able to respond in a timely manner. So I think there's an awful lot that we can add to value. We've adjusted the report this time to try and reflect more of the examples so that you get the story behind the complaint, because it's not fair to service areas just to purely see that a complaint's come in. It's to put it into context, both from the customer and from us as a provider, and what those dependencies are. So certainly what I'm building into the development of a new complaint system is that we can see how other third-party providers, especially in these type of settings, have an impact on the overall perception of what we deliver as an authority. So it will be something that's in development. We are hoping to make changes to, the future reports that are coming out. So that I think it's unfair, again, with this type of service that and the things that we deliver, that it's just purely based on stats, because stats don't give a true reflection you know, we can all manipulate data, and I shouldn't, you know, at the end of the day, we can actually build a better picture of what we've done, what the lessons learned are, and what those service areas are working really hard to put in to make sure some of the comments and complaints have come back, you know, are brought into their business plan and moving things forward where things, you know, unfortunately sometimes do go wrong.
Thank you, Lynn. I think that's what I was rather maybe perhaps too subtly or too densely trying to get to.
Yeah, no, thank you, Lynn, and welcome on board as well. Welcome to Calderdale. It's always nice to see new faces and new input to the systems. We have Helen Hunter from Healthwatch. Welcome once again to our meeting.
Thank you. I've got a couple of different things that I wanted to sort of reflect on. Firstly, and I think this first question ties into what other people we've kind of already touched on a little anyway. So obviously this is complaints that have come in directly to Calderdale Council related to adult social care, but a number of people will complain directly to their provider of service rather than to adult social care about the quality of their experience. And I don't know what level of understanding we have of the volume of complaints, what investigations for those look like, how other agencies utilise learning from the complaints process, you know, where we would commission that service or you know, provide funding to that service in order to deliver some care in terms of people with social care needs. So there was that was in my mind. The other thing that was in my mind, and forgive me if I've missed this in the report, is whether we have a breakdown of whether the complaints that are coming in are from carers or from people with lived experience of having a social care need. Because one of my nervousnesses about adult social care complaints is that if you perhaps have social care needs, you are not necessarily in a particularly well-equipped and empowered place to speak out about the quality of your experience. And that if you have a carer who's really passionate for you, then they might actually well speak up on your behalf and raise a concern, but you might not necessarily have the skills and the competencies or the will, the strength to be able to raise a concern about something that's happened in regard to your care. So I'd be interested to know what kind of the breakdown is in terms of sort of, is it carers, is it people who receive social care directly? And I think something really important, and I've talked about this before with Scrutiny, about the fact that if you make a complaint about the NHS, you have an entitlement to advocacy support. We provide that advocacy support in Calderdale. So if you want to complain about your GP, even if you have no sort of vulnerabilities or barriers in terms of communication, we can support you to do that. But somebody receiving social care doesn't have access to the same advocacy to raise a complaint or a concern about their care. And it makes me nervous that some of those people perhaps aren't equipped as well as they ought to be to speak out. And bearing in mind that obviously social care can be far more personal long term, it's actually much harder to raise complaints about those types of service anyway. So I just think that there's something about understanding that context and what support might be available for people, as well as some stuff about a clearer picture.
Okay, who wants to come back on that element? Lynn, Richard, somebody? Not getting a response, Helen. I'll be
possibly in to come back on that, because it's about actual service delivery rather than from the view we're taking.
Yeah. Is it okay if I could?
Yeah, of course. Yeah, yes, Ian, please. Yeah.
So I'll deal with the provider issue first, if that's okay, Helen. So we do know that we get a percentage of our complaints that formally come to the local authority, and we often ask the third-party provider to undertake their investigation. So we know that we formally, when we have a formal receipt of a complaint, we get a very early view on the approach that the provider is taking. What we also do through our commissioning and contracting approach with our providers is to understand the level of user customer feedback, including complaints, and that's part of the regular quality monitoring. What you also will have as a to help keep the kind of approach of the provider in focus is if they're a regulated provider, i.e. via CQC, CQC will also be asking questions through their inspection framework to look at the complaints, and will receive whistleblowing, as will the local authority. So I think there's a broader picture on that. I think to try and address your question about the power imbalance of someone who's in receipt of service making a complaint, what I don't have is the formal breakdown of those figures, and hopefully we can, through the complaints process and the new system, provide that going forward, I think. But I think there is something about, we know that we'll be working with some people who will find it very difficult to represent their own views on the quality and level of care. So as part of the Care Act assessment process, advocacy can be included, but it's not specifically to a complaint process. So there's a different legislative framework that operates. So I think I agree with you that I think it would be helpful if there was a statutory advocacy complaints process for adult social care, because I think we would get a wider view of what that looks like. Certainly, I think I tend to, as director, when I receive a complaint, it's usually at the point where people have been incredibly frustrated through the process. So but I think on balance, I see them from both people who are in direct receipt, but also families. And I think the important bit for me is, in all of this, is ensuring that we really do listen to whoever has made that complaint, what's important to them in terms of seeking a resolution, but also acknowledge that sometimes we do get things wrong. We don't always get that right, but focusing on how we can improve it for that individual, but make sure we learn and implement the learning across the directorate to make sure that we don't make those mistakes again.
Thank you, Ian, for that. Councillor Swift. Just on mute still at the moment, Councillor Swift, sorry.
Come on.
There you go. That's sorted.
Thank you. Yeah. Well, I'd hate to disagree with both Councillor Barnes and Councillor Hutchinson, but actually it's quite easy to do. No, it was a good report. I did lose the will to live when I got partway through it, because I couldn't work out in somebody what it was trying to tell me or what I wanted to get out of it. But I haven't seen it in that format before, I don't think. And yeah, no, it was good. What I don't understand is those are complaints from, I don't know, people outside the council who are using council services. What happens if we make a complaint? How's that dealt with?
A good question, actually. Who would like to come back on that? Ian, do you want to come back on that? Just as an overview, are our complaints logged differently?
So in terms of where either an MP or an elected member of the council raises a concern, there's a log and they are responded to. That wouldn't be fed through the complaints process unless there was a formal request for it to be dealt with as a formal complaint. But where there are inquiries to understand where things have gone wrong, there is a formal logging of those requests, and we then respond directly to the person raising that. If Councillor Swift has got some examples of where she's heard from colleagues where they feel that those issues haven't been logged or responded to, it would be helpful if maybe offline we could understand what they were in order that we can make sure that that does happen. I think the important bit is making sure that it's formally comes to myself as director, because then I can allocate someone to do that. I think occasionally what can happen is people may go to a direct officer, and then obviously I won't be able to have that logged, but my executive support and myself we make a log of all inquiries that I'm aware of, and then we ensure that they are responded to.
Excellent, thank you, Ian, for that.
Thank you. Chair, can I just make very clear that I haven't picked up any, excuse me, I haven't picked up comments from anybody thinking that wasn't done. It was just something I didn't know whether it was done.
Yeah, no, it's a good question. So yeah, thank you for that. Councillor Kingston.
Thank you, Councillor Bladborough. Just my reading of the report, and I'm aware I've possibly misunderstood it. I've never been brilliant with bar charts, understanding bar charts, but the standard is 15 days, I understood. The target is 15 days response time. And my reading of it, it looked like most of the complaints, the response time was 3 or 4 times as long as that, which, first of all, have I understood that correctly? Have I read that correctly? Is it me that's misunderstood the data? And then the second question is related to that. If I'm correct, I hear that you say it's because of the pandemic. I wonder if you could be more specific. How has the pandemic impacted response time? What specifically has about the pandemic has made it so slow to respond to complaints that if we are missing by 3 or 4 times our target, it's taking 3 or 4 times as long as we want it to? Why is that? Thank you.
Yeah, thank you. Richard, do you want to come back on that?
Yeah, so yeah, it's correct. The time scale is estimated at 15 days. That's what we like to aim for. But the reason being where the pandemic was, we're saying that had an influence, is because we have a set amount of people who investigate complaints within adult services. And at the time, they're kind of, when the first lockdown occurred, their time was basically putting the care of the who needed care, and kind of acknowledging complaints was done by us, but it was put on the side, like on the back burner, while they got on top of all the PPE queries and all them stuff. So it was kind of unofficially agreed that we wouldn't chase complaints as much as we normally would do.
Thank you for that. Ian, you've put your hand up, so do you want to come back in on that?
I think I just want to offer some assurance, and I think I agree that certainly when I know I receive a poor service from somewhere, I want my complaint to be understood, dealt with, and resolved as quickly as possible. And I think the pandemic has made it difficult, but I don't think we should hide behind the pandemic. We should strive to resolve that at the earliest opportunity. And I think one of the things that we've just committed to as a directorate is to aim for an improved performance on things being resolved within 15 days. We are still recovering from the pandemic. We're still seeing some of that backlog. So at the moment, I've asked by the end of the financial year, I want 75% of our complaints to be responded to and dealt with to satisfaction within 15 days. And then for the new financial year, we'll be setting a higher target. I think the sooner you can understand what's gone wrong, you're more likely to be able to satisfactorily resolve that for all people. So I think the pandemic has made it difficult, but I don't think we should hide behind it. It's not the performance we would have wanted, and we know we want to improve. And I think most people would say that they would strive to do that. And some of the ones that have taken in excess of times, often that's been where we've needed to get third-party information, and that has added to the length. I would hope we would not see those being in future reports.
Thank you, Ian, for that explanation. And likewise, Councillor Durans.
Thank you, Councillor Bladborough. Sorry to go back over a couple of points. Around the advocacy point that Helen raised, and then Ian answered it, and it was really helpful. But again, there was reference to the family members being available. What about people that are not necessarily supported by family and might live with daily carers or ever-changing carers? How are we making sure that they feel that, you know, things are not going past and their level of care is just as important as anybody else's, and we're catching things when they really need to be caught, and they're not just accepting it because they've got no other skills to get beyond that?
Yeah, thank you for that. Richard, do you want to come back on that?
All right, can you just repeat some of that, because it proper broke up?
Oh, sorry, is this better?
Yeah, a bit. Yeah, sorry, I heard some of it. If you could just repeat it, sorry.
Yeah. So what I was saying is, when we consider that somebody may have communication challenges or difficulties in advocating for themselves, we rely heavily on their carers or their family members to do that. But that's not always the case, because some people live at home independently with carers or in other settings. How do we ensure that their care is the same level, the expected level that we know that everybody else has got, or that they've got the opportunity to challenge that if it's not? How are we catching those views, and what's in place to safety net them?
Richard, do you want
Sorry.
Do you want Ian's put his hand up, so I'm not quite sure
Yeah.
if he's got a response to that. So Ian, if you want to go ahead, Ian, then we can come back to you if necessary.
Thank you, Chair. So I think in the way that I would probably respond to that is that through the formal care assessment, social work assessment, we should really early on identify if someone has any particular communication barriers and understand what their family, friend, caring network that's sat around them. And I think one of the things that we know we can do, because we do have an advocacy contract that's not specifically about supporting them through a complaint, but being where people may have either communication barriers, for someone to be able to advocate on their behalf. So if we've done the assessment right, we should be able to identify those people who might need some support to get their views expressed and communicated. Now it may not happen in all situations, but I think one of the things that we need to make sure is that through our quality monitoring of providers, we also try and understand how providers are making sure that they understand and are delivering on the care needs of some individuals. So I don't think we've got it cracked 100%, but I think we have mechanisms in place within the resources that we've got, and I think that that's something that we might need to look at. Maybe we could do some work this year to understand through for a quarter of complaints, as in a quarter of the year's complaints, look at understanding the experience of people who have made those complaints, and actually about did they feel able to make the complaint? What were the barriers? So we can maybe start to think about what some of those things are. Certainly one of the things that I try to do when we've had really difficult complaints is I will always try and meet with the person who's made the complaint, whether that be the individual themselves or a family members, but doing it on their behalf, to kind of understand what we could have done differently. Did the outcome of the complaint resolve that for them completely? And actually, what I have found with is that people are often really keen to help us understand how we can improve things, and we'll get involved in us making some of those improvements. So, for example, we recently had a family member who'd found it really impenetrable to understand some of the financial assessment letters that were sent, and to be honest, sometimes I do, and I've done this job for quite some time, and it was about how do we put things into really simple, straightforward, plain language that is accessible, so that what that person's done is worked with us as almost a kind of reference group to kind of work through how we can make some of that communication better, so we learn and improve. I'm not sure if that completely answers your question, but hopefully I've gone some way to explain it.
Thank you.
Thank you, Ian, for that. So, Councillor Fenton-Glynn, welcome to the meeting.
Yeah, sorry for my tardiness. For some reason, I knew this was happening, but then when I tried to log in, it disappeared from my diary. Where I was going to make a point which is kind of similar to that which Ian's just made, which is that I think one of the things that I would like to see is the number of complaints going down, as well as how quickly we deal with them. And I think, that has to be part of our process. And we were talking in our team meeting earlier this week about this. Part of our process has to be that a complaint, particularly a complex one, where there has been, some us falling short somewhat, where that happens, we need to make sure that we are learning from them. And actually, Ian gave an example in our meeting of a recent case where at the end of the process, we talked through the family members. The thing that we could confidently say was that similar things wouldn't happen again. And actually, that's a successful complaint handling process. But it is, we don't expect to get everything perfect. The problem is when you make the same mistakes multiple times. Make a mistake once, it's a learning opportunity really, but make a mistake multiple times and it's a systemic failure. So one thing that I would like, I'd like us to look at is how we're learning from the complaints and make sure that we continue to do so. Those captions are really distracting.
Excellent. No, thank you for that. I think it's something that we would like to be involved in as well. So, Lynn, you've got your hand up. I'm presuming you want to respond to something that's already been said.
Yeah, just very briefly, I think one of the things that we shouldn't overlook is when we have a benchmark to respond to customers in a timely manner. And that's something that, being new to Calderdale, I'm keen to review. I've got a previous life of 20 years in local authorities, working for a combined authority, looked after complaints and comments, from that side. And I think what shouldn't be overlooked and is perhaps not evident in the report is the engagement that we have with the customer from the very beginning. So to simply put the timeline on something and to go over that timeline is not necessarily a failure. It means that we're properly investigating that and we're looking at what the partnerships are that we're dealing with and what issues they are up against. And if the exception that we've had throughout the COVID period is everybody was in a period of learning. So where we've got an extension of something that would be resolved quickly, there were many barriers that lots of partners have had to face, imposing new ways of working for staff, people not necessarily following it, and all the mental health and social impacts that went alongside that. So when we get back into this period of stability where we're simply then concentrating on delivering a service without the encumbrances, that we've experienced in the last 18 months, we can look at, are these timelines realistic? I've looked at the notes and said, seeing that NHS is 6 months. When we look at some of our other authorities who have benchmarks of 20 days for a response, I would always sort of err on the side of caution. That's something for us to perform against, but that's not necessarily, if we hit everything at 15 days, I'm sure Ian would echo that. I might be a little concerned, depending on the type of comment or complaint that's come in, because we've not had the opportunity then to perhaps interview staff, interview service providers, actually deal with the impact it's had on the individual who's making the complaint in the right manner. So I would, that's just my personal thought, in that we can very much get tied up in the data, and we have to show that because we've got to show, as an authority, how we're performing and how we're responding to customer. But in these sometimes emotive situations, it's key to remember that there's a person at the end of this process, someone who has felt the need to make that comment and complain, and that has to be dealt with alongside the key staff that are delivering those services as well, to look at the gaps on both parties, and make sure that from that lessons learned, which is certainly this service area is looked at very strongly, and work with us, over the years to make sure we get our procedures and policies right. I'd just say, informally, don't get hung up by the numbers necessarily. It's the detail that goes with them and the outcomes that we deliver from those details.
Thank you, Lynn. Yeah, thank you, Lynn, for that. We'll look forward to working with you. And I think the key on this one, as long as the person at the other end is communicated, as to actually it's taken a bit longer than what it would normally do, because actually we're looking into these things. Because actually, in the past, I think that's been part of the issue, is that nobody's known it's going to be on 15 days, which is, as you say, is right. But equally, you're just an explanation. Actually, it's taken us a little bit longer. Yeah, we'll come back to you as that communication. But I'm sure you have that in hand. So I'm going to bring in Councillor Swift in at this stage. There we go.
Yeah, thank you. Yeah, just a quickie, Chair. I'm wondering, and I mean, it's not whether this is the right format or not, I don't know. But if you go to some of the West Yorkshire meetings, they have people who use the system there, and they're not always people that haven't liked what happened. It seems to try to be balanced down, but it means there's a different group of people occasionally that we're listening to, and not just ourselves. And it's usually, I don't know how you do it, but you get somebody who comes along, and say, well, I did A, B, and C, and it worked out when I contacted such and such, which would be much better than people shouting at me on my Facebook page, which I can't do a lot about. And some people don't know what to expect. But I'd like to see, some way or other that we could fetch people who are using the systems in. Don't know whether it's possible, but I'd like it to be thought about.
It's certainly food for thought. I think it's a good thought on that one. I'll bring Colin Hutchinson in, and I don't think, Ian, you're not indicating to speak again, are you? You've got your hand up. Oh, you are. So if you'd like to come in then first, if that's okay.
I'm never quite sure if it's really useful to disagree with your portfolio holder in one meeting. I think I do have an ambition that we have fewer complaints, but I would worry if we had no complaints, because that would suggest to me that the systems we put in place make it inaccessible for people to make complaints. We are dealing with really complex situations and people's lives. So I think we have to recognise that people will not always be satisfied with services. But I would be extremely worried if we had no complaints whatsoever, because that would probably mean that people have given up and don't think we're able to listen to them. So I think there is something, and I think Lynn's right, is that there isn't a legal requirement on local authority to respond by within 15 days. It is an ambition. I think the important bit for me is making sure that when we're negotiating with an individual about their complaint and the outcomes they're trying to achieve, that we're clear about what's acceptable for them in terms of the length of the investigation. So for some people, they will say, I'd sooner it took 3 months and it's done well than the importance of it being done within a matter of days. For others, it's really important that they have a really quick resolution. So I think part of that, the skill of the investigating officer is to really negotiate what the outcome the person's trying to resolve, but also the kind of time frame, and making sure, as the chair has indicated, that people are kept communicated with at each stage of the investigation and not left thinking, is anything happening?
Yeah, no, absolutely spot on. Councillor Hutchinson.
Over many years in the NHS, I investigated large numbers of clinical incidents and complaints. And Lynn is absolutely right that it's capturing the learning from those incidents that's so important. But the people who are directly involved usually learn those lessons very clearly, and it's not many of them that go and make the same errors or errors of judgment the second time over. But it's how do you actually get the learning from those events out to everybody else so that they don't have to learn by experience. And, you know, I was just wondering how you go about doing that, whether there is a sort of compilation of wisdom that you gather that everyone has to learn by rote, or you know, how can you achieve that so we don't always have to learn by our individual mistakes?
Good question. Who wants to come back on that one? Ian, sorry, do you want to come back on that?
Yeah, Councillor Hutchinson's hit on a very important part of the process. So alongside the completion of the investigation and writing an outcome letter and giving that to the complainant, there is a process that sits alongside this called the learning log, which identifies the key learning for either individuals or the service. And what we then do is we take a look at all the learning from complaints, aggregate that up and work out, were there some themes, for example, around a lack of clarity around policy and procedure? And then do we improve the policy and procedures from that learning? Some of it is then converted into briefings and training across the directorate. So we do aggregate up individual learning to understand key themes that have occurred in the year, and apply that either through briefings, changes to policy to make that clear, or through formal training. And it definitely becomes part of the training programme.
Thank you, Ian. Right, nobody else has indicated to speak on this item. I think we've given it quite a lot of airtime. It's been extremely useful. Certainly look forward to working with Lynn with her ideas from other authorities, and we'll, you know, certainly receive this report. So we'll move on to item number 6, which is hospital outpatient survey. Yeah.
Sorry to interrupt, Councillor Blackburn, but there's also the CCG report on this item as well.
There is indeed. My apologies. Yeah. Penny, would you like to welcome, of course?
Yeah, of course. Hi, everybody. My name's Penny Woodhead. I'm the Chief Quality Nursing Officer at Calderdale Clinical Commissioning Group. I've been to Scrutiny previously for the annual complaints report. Generally is part of a suite of other documents around experience of care within the NHS that our other NHS partners provide or participate in. And I do know there's at least one other NHS colleague that's on the call, Chris Lennox from Swift. I'm not sure whether there is anybody else. So you are only seeing one part in terms of a written report around the NHS complaints processes. So it is an annual report that's been received in our governing body earlier on in this year. There are fluctuations in terms of the numbers within the report, which are to do with the pandemic. The NHS was instructed to pause its complaints process at the beginning of the pandemic and then reinstate that during the summer of 2020. So there are changes to the numbers over the years, and there's also a change in terms of the complexity of the complaints that the CCG handles. So a bigger proportion in this latter year in relation to what we call level 1 and level 2 queries and concerns, which are often about things that can be remedied very quickly or signposting. The CCG only handles a very small proportion of complaints in relation to the NHS. People that wish to make a complaint can do that via a number of routes, either directly to their provider of care or to the CCG. And often when people come to the CCG, we have conversations around actually, are we best placed to handle that complaint? And in many cases, you'll see in the report that those complaints have been passed back to the providers. We also have a responsibility to assure ourselves of the complaints processes of our providers, and we do that through a variety of mechanisms. And I've been listening with interest to some of the questions and answers, particularly from Ian, and I was struck by the timescales, because answering very quickly to deliver a poor response is not great. What I'm interested in often with our providers is the reopening of complaints. So that indicates to me that the complainant has not been satisfied with the response, and rather than get fixated on a 15 or a 40 day or a target, often that reopening of complaints is an indicator of the quality of the complaints functions. So, you know, you've got the report. I'm quite happy to pick up questions and talk particularly about the how we do the learning from an NHS point of view, because I'm sure you'll be interested in that.
Yeah, super. Thank you, Penny. Helen, if you want to come in, if you can make your question quite brief, it was so we can understand what the question is. So I know last time it was useful, but it's if that's okay.
That's absolutely fine. Sorry, so what I wanted to offer with, because obviously Healthwatch provide NHS complaints advocacy, I wanted to provide you with a little bit of insight from our service in terms of what we are dealing with from the perspective of making NHS complaints, and things that perhaps have surprised me a little. So we are busier than ever in terms of providing NHS complaints advocacy, and I would say that the complexity of the cases that we are dealing with is actually increasing alongside the needs of the people that we are dealing with as well. I think one of the things that feels very clear to us is that people are fraught and struggling, and managing some of the emotional challenges that some people are experiencing is becoming a bigger part of delivering our NHS complaints advocacy. What I would say is that we haven't had a shift in complaints in terms of stuff related to access with COVID. So I thought we might start to see an increase in complaints related to sort of delays or sort of limited access. I think, much as Penny's described, we've had more queries where people have asked us about sort of like what is happening with my care. But in terms of complaints, it continues to be about sort of more ingrained experience that people have had across a longer period of time. And what I would say is that we're seeing quite a lot of complaints that relate to mental health, and we've done some work closely with Swift in order to make sure that our insight's been properly captured there. And there is increasingly a crossover in terms of their needs that people have between health services and social care complaints as well, where people have issues with multiple parts of the system and are wanting to raise concerns, often about the gaps between what they experience. It's very hard to complain about gaps because, of course, the responsibility doesn't sit with any individual provider. But I just wanted to kind of provide you with that insight, that's all.
Yeah, that's really helpful, as always, when you attend our meetings.
You've gone on mute, Howard.
That was a very impressive.
Indeed. So so my apologies. I don't ever do that. So my apologies. I think someone who's coming past very, very loudly. So it's always useful to have your comments on board. So thank you for those. So Councillor Barnes.
Thank you, Chair. I will keep mine brief. Section 2.6, Section 2.7. Pause of the NHS complaints process at the end of 2019-2020. Surely we should mean that is 2020, because the pandemic wasn't in the UK in 2019. So just wanted to make that reference there before Councillor Fenton Glynn texts me to call me a pedant. I will call myself a pedant on that one. But the second point is, you obviously said there were complaints were acknowledged and appropriate logged. How many complaints were received during that period of time? Because unless I miss it, there's no reference to what happened to those. There's reference in 2.7 to what happened to the complaints that were outstanding at the period of the commencement of the pause, but nothing in relation to those that were received during the pause period.
So the reference around the years, Councillor Barn, 2019-20 is financial years that the NHS operates within. So the pandemic.
I think my point, Penny, is that if these reports should be about, should be easily readable by the general public who wouldn't understand that, and that's my point. Yeah.
Okay, that's fine. I think it's very common parlance in our CCG report like this in relation to the numbers of complaints received during the time they are included within the overall numbers. I would have to go away and ask my complaints manager for the very specific number that were received during the complaints pause process. They are included in the overall numbers.
Okay, thank you, Penny, for that. Mike, you've still got your hand up. Are you still indicating you want to speak?
Thank you, Chair. Just to say that Chris is here from Swift as well, although there isn't a report. He has some information to add in terms of Swift issues.
I think she does. So, Chris, welcome, Chris.
Hi, thank you. There is a report, actually. It was circulated with the invite to the meeting, but I note it hasn't been embedded within the papers. So we did provide a report, which is available, and it is on the invite, the Zoom's invite to the meeting. The themes that we covered are pretty much what people have been talking about already. And our, as I say, the report is there, but it pretty much around how we've worked with people throughout the last 18 months to continue that dialogue and to deal with concerns. And we found that a very productive learning exercise. And as other colleagues have, Ian has mentioned, the rich learning that can come from that, and we've turned that, and we've got evidence in our report about how we've converted that into service improvement, which has been really encouraging. We do mainly keep to the timeframes that we set ourselves, and most of our complaints are within the 40-day response, so they are the more the ones of higher complexity. But we do deal with a lot of issues as service level issues, and they're turned around in days. And we do attempt to obviously resolve things as close to the frontline as possible, and find that our service users welcome that and use it as a building platform to improve relationships. We have done a big piece of work, as I said, about learning from complaints, and we've got that information there. And the themes for us really have been around, I think, access has been one, about simplification of processes, but pretty much around access for services as well, and about access to treatment and medication, and about how we communicate with people. So we have aggregated the, obviously our pitch is a total one for Wakefield, Calderdale, Kirklees, Barnsley, the areas that our trust covers, but we have actually separated out in our report for Calderdale, but it's not an untypical picture for Calderdale in terms of our wider setting. But if there's anything that anybody wants me to expand upon, I'm happy to do so.
Yeah, thanks.
Yeah.
Yeah, thanks, Chris, for that. That's extremely useful. I don't know if people need to be aware I'm Governor of Swift. I don't know if I need to declare an interest, but equally, if members have any feedback that I can feed to the meetings, I'm more than happy to do so via email or whatever. Nobody's indicated to raise any question. Mike Lodge.
Sorry, just to say, Chair, Chris, I don't know what's happened to why the report isn't embedded in the papers. We'll recirculate it to members. Thanks for providing the report. We also, two things very briefly, Chair. I know you want me to be brief. We will be getting a report later. I mean, this refers to something Penny said. We will be getting a report later in the year from CHFT. I mean, I think in a sense it's a good thing we didn't have the report, otherwise we'd still be on complaints till 7:30. And just for your information, well, for everyone's information, Fazana is having some technical difficulties, so we're doing some work behind the scenes to get her back in. But you're relying on me to a greater extent than you really should be.
I'm sure we're more than safe in your capable hands. Right. On that note, we will move on to the next item. So thank you, members, for attending for that item. So item number 6 is hospital outpatient arrangements. Who would like to set us off on this? It's a verbal oral report.
That would be me, Chair.
Oh, super. Hi, Lisa. Welcome to the meeting.
Hi. Good evening, everyone. My name is Lisa Williams. I'm Assistant Director of Transformation and Partnerships at CHFT. I do have my colleague, Emily Dewey, with me. Give them a wave, Emily.
Hi, Emily. Yeah, hi.
Patient Access and Validation Manager. I do have a short presentation, if that's okay, Chair, if I can share that with you.
It is. I'm sure you can. If you've got the facility to share. I don't know who normally would give you the facility, but if you can do.
Here we go.
Yeah, we've got it. There we go.
Can you see that?
We can indeed. Yeah.
Brilliant. Let's see whether it's letting me do it onto a slideshow. Not sure it is. See if I can make that bigger. I'm not used to Zoom. I'm used to Teams, I'm afraid. So as I said, thank you for inviting us to give an update on hospital outpatients. As we all know, the landscape for hospital outpatients changed when the pandemic came along. It changed significantly. You will recall that in April 2020, there was a mandate to restrict the acceptance of referrals into outpatients to urgents and cancers or cancer-related illness. That wasn't a local decision, that was a national decision. We were, as a trust, in a fortunate place in comparison with some of our local providers, in that we have been working on some new models through our outpatient transformation programme that enabled us to start some different models of care, some virtual models of care earlier than other organisations did. And that helped us maximise some of our capacity and protect some of our most vulnerable patients. I just want to put 2020 into context. I'm not going to spend a long time on activity because I know that's not the brief. It's more about process, but just to share with you, to put into context where we've been over the last 12 months. When we look at our planned outpatients that we agreed with our CCG, our pre-COVID plan, which is based on year trends of how many outpatients appointments we will do and perform in a year. In 2020-2021, which is our financial year, we delivered 78% of that plan, which, given the fact that we had closed down for a significant period, was quite an achievement. 51% of that was face-to-face. I know there's a lot of narrative in the press at the moment around everything is virtual, but 51% of that was actually face-to-face, because a significant part of that was urgence and cancer treatment, which we never stopped doing. 49% of that was through virtual, which is telephone appointments, video appointments, group appointments, and so a different model of care, which I'll come on to in a moment and explain to you. The face-to-face appointments over the last few months has increased as virtual's gone down, as we've started doing more and more face-to-face, but we do still have restrictions in place within hospitals around capacity and social distancing. So we are trying to maximise our clinicians' time as much as possible. Community adapted very well, and our patients adapted very well to video appointments for things such as video appointments in MSK physio. We know that there's been a shift from our engagement with patients. We know that there's been a shift in acceptance for virtual appointments over the last 12 months. We've developed group sessions for things such as speech and language therapy, diabetes, cancer, which has had some really useful feedback, and we've continued with that over the last 12 months. Just to share with you a slide really. I mentioned that we never stopped doing our cancer patients, and our performance for locally has maintained our cancer performance very well. If you look on the top right-hand corner graph on your screens at the moment, it shows our position in relation to other organisations across West Yorkshire. We have managed to keep that going very well. But it's not all a great story. There has been, if you look at the slide on the top left-hand corner, there has been a trend, an upward trend in people waiting to get access for appointments, and that trend we are just starting to see that turn downwards now. And the reason that's turning downwards is because we've secured more capacity. So we are using the private sector, we're securing capacity with the private sector for outpatient appointments. We were one of the first across West Yorkshire to open our books again to our GPs, and as you will see there is a peak. That is when we opened our books and the patients were transferred across. What we did was we worked with our GPs to peer review some of those patients to say, are there any alternative ways of getting patients treated more quickly? Are there any trends where we can develop new pathways or relaunch old pathways that just need a reminder or need some training? And we did a lot of peer review there and some clinical interface sessions. But we've had to look more creatively about how we can see patients and how we use things such as advice and guidance more, where instead of just traditionally referring a patient, can we provide some advice and guidance that can go straight back to that patient? When we think about an outpatient appointment, The process has always been a patient goes into a GP practice. If they feel they need a secondary care referral, they are then referred through the choose and book system. They're given an appointment, they come and visit the hospital. They have multiple appointments. In a lot of cases, those multiple appointments weren't necessarily needed. So what we've set up, and we piloted this pre-COVID, is something called a clinical assessment service, which is a step on from advice and guidance, where we have a full clinical review. Now, we piloted this service in gastroenterology and in cardiology pre-COVID, and had some really good patient outcomes. We'd had some really good patient feedback and engagement with general practice as well. What this model does is GPs will refer the patients into a CAS clinic. This is a job planned clinic that is an online clinic. The patient isn't present, but the clinician will have access to all the information that they need. We have been working closely with GPs to make sure that we are getting a minimum data set that we require for these. It's not perfect yet, but we're working on it. With the clinician then reviews to see what's the best next steps for that patient, and where we can provide that advice and guidance back, we have been doing so. But what we have found is about 75% of patients are being referred straight onto tests, and that's for 75% of patients taking out an unnecessary appointment, so they're not having those multiple visits. We've invested in some support from coordinators, some admin support, to make sure that patients are communicated with, they know what's happening, and that their tests are booked and coordinated back. Their results are going back to the clinician in a timely way. And it may be that we do need to see these patients, and after that first review, they are then booked in for either a face-to-face appointment or a virtual appointment. We've now rolled this out across 14 pilot specialties, and seen around, it says 19,000 there, it's up to about 20,000 now. Patients have gone through this, and this has allowed our clinicians to see more patients more timely. Because the patient's not there, they are actually reviewing more. And because we're cutting out 75% of first appointments that are unnecessary, again, we're maximising our capacity to start bringing that trend down and start bringing our waiting times down for patients. Now, that's for first appointments. But one of the things that keeps me awake at night is around the follow-up appointments, and the people who are in the system, who have been in the system for a long time with long-term conditions, that are used to having a 6-monthly or an annual review, and they're just not getting that at the moment because we haven't had the capacity to do that. So what we've been doing is working very hard with our clinicians to say, how do we prioritise? How do we do clinical reviews? All our patients who are waiting for a follow-up appointment are clinically reviewed in their clinical records by a clinician to say, how quickly do we need to see these patients? Now, that backlog is now stabilising. It's not creeping up anymore. It's stabilising because we are managing to create that capacity to see more people. But we're also looking at, are there any other ways that we can keep in touch with patients? We can provide them and empower them to contact us when they need to contact us, instead of coming every 6 months to sit there and say, you know, we've all been there. You come in, you can't park, you sit there in a waiting room and you say, I'm okay now. But a few months later, you may have a flare-up of your condition, and then you're going back to your GP to get a re-referral in. So how can we support people? So we've been working with our clinicians, with our primary care, and also with lots of different patient groups to say, what do you need from a pathway that empowers you to self-care, from something called patient-initiated follow-up? And when you need access, how do you want to contact us? So we've been working with things such as, we've been working with Health Watch, we've been going out to practice management groups, to clinical reference groups, and we've been working with some of the protected characteristic groups. Pre-COVID, Health Watch did some engagement with us, and they engaged with over 300 people from protected characteristic groups to see how they can use virtual care. We've done some simple things such as work with the Blind Society. You'll see how our logos here, our patient information, What do you need on the information? And there were simple things that we hadn't thought of, such as for people who have difficulty with sight, it's easier for them to see things on yellow coloured paper. And one thing that really stuck with me was around, someone said to us, actually, when you translate things into an audio, how you read it is very different from hearing it. So we are working with the Blind Society for them to actually translate our information into audio in a way that is easier for people to understand. So we've got pilots at the moment in rheumatology and gastroenterology, which they've only been up and running for 2 months. And they are working well. We're getting some great feedback, and we're looking at what other services we can roll these out to. You will know that there's some national targets around PIFU now, but what we've said is we want to get this pathway right, and that's why we've done the level of engagement that we have. Now, in the brief, you asked if we could give an update on the action plan that we shared with you pre-COVID around an independent review we'd had around our appointments process. As you will recall, that report that we shared identified 3 areas that we needed to do further work on. One around how we communicate with patients, and in particular around the letters that we were sending out. And people accessing those letters and them being appropriate. We just deployed a full electronic patient record, and there were some system issues around some data quality issues, but not all were data quality. Some of that was around user issues, and I don't mean patients as users, I mean staff as users and colleagues, and around what training we needed to put in and how we needed to amend the system to make it work better. So I just wanted to share with you that action plan has been completed. That has been closed down. There are some areas that are being taken forward in some existing groups, such as our data quality board, our outpatient transformation programme. But just to share with you some of the themes that came out of that and some of the action that's been taken. So patient communication was a big issue that came out of that report, and especially around the letters. And we've been working very hard to move onto a more accessible digital letter, making sure that the content of the letter is there, but we were having a problem with pulling the data across. So not everyone could access that digital letter because that minimum data set wasn't there pulling through the system. So we've been working with our GP colleagues to make sure that we get the data set right from the GP at the start of the pathway, and making sure that we have that populated within our system so that that can be pulled through. There was an issue around patients not accessing being able to access the digital letters. They may not have a smartphone. You know, I've talked to members of Scrutiny before on both sides of the patch where it's been reported that it's going through to Wi-Fi enabled phones, non-data enabled phones. So we have now put a backup system in place that if those letters are not accessed within 24 hours, a paper letter goes out. We've changed the wording. What we've picked up through COVID is the wording wasn't right for when it's a virtual appointment and was causing confusion. So we've been working with our third party providers who do those letters for us to make sure that we get that right. And we're still engaging with patients now to say, is this working? What can we do better? Our booking processes, we weren't maximising our capacity correctly because consultants were booking in through a functionality that said they had a 3-month gap. So they were saying to our booking team, patients need to be booked within this period. We now work it, which caused confusion. We're now working on bookings on a month-to-month basis. And we're working with our clinical teams to say, where is the demand and where do we need to focus any capacity to meet that demand, to try to even that out. As you can imagine, that is difficult at the moment, but it's also essential at the moment to make sure that we are making access for where we really need it. There's been, as I said, the data quality, making sure that that minimum data set is there, and making sure that we have visibility at an organisational level and the governance in place to make sure that we are monitoring that. So we have that in place now. And we can see on our knowledge portal at what stage any waiting list is and where patients are in their pathway. Pre-COVID, We refreshed all the training, but unfortunately we had to close down the face-to-face training. So now we've developed some training packages that are online, and we've developed video clips and a digital user MDT to try and enhance that. Running alongside that is our outpatient transformation programme that's in its 3rd year now. And what we found during the last 12 months is some of the models that we tried and piloted pre-COVID, as I've described some of them, we've been able to roll some of those out to give us that extra capacity. But what we've also learned over the last 12 months is working closely with patients and that engagement and with primary care is around where we really need to focus our efforts. And we came up with a 10-point plan, which is owned by our system partners in our outpatient transformation. And we have patients on our outpatient transformation board as well as Health Watch. And we own this plan now because these are the 10 areas where we can feel that we can really make a difference. And one of the key themes that runs through our outpatient transformation programme is around inclusivity. A lot has moved to digital over the last 12 months. And whilst when we've done our surveys with patients and we have engaged with patients, there is more of an acceptance. Quite often people still need to be able to pick up that phone and speak to a human being. We also don't want to exclude anyone unintentionally by digital developments. So we're working with local authority groups to make sure that we to work on things such as digital hubs and digital literacy and digital poverty. And we're working at an ICS level to see how we can provide some training and some packages within the community and further training for colleagues as well. I'm happy to take any questions and I'll stop sharing the screen.
Excellent, thank you, Lisa. Can you just share your screen and go back to the, yeah, that's better. Thank you. I've had first-hand experience of the data assessing is I actually found it really useful and really helpful, but I've got a smartphone. So, right, the order I've got it in, so my apologies if this isn't the right order. The Councillor Swift first, please.
Hey.
There we go, got it.
Yeah, sorry, I don't know whether it's me or the computer. I mean, there's an awful lot of work going on in the background, which is quite clear. If you're going to make it public that you're doing yet another remote way of getting appointments and not getting appointments, etc., will you let me know and I'll turn my Facebook pages off? Because at the moment, however much people on professionals say, this is ideal, we can do this and we can do that. Well, they can, but you know, I've got a 3-year-old grandchild that keeps having respiratory problems. Get the GP, oh no. So you finish up going to A&E, which you're told you're not supposed to do. And it's then that people are getting upset because they don't want to make a decision that they're going to get to A&E and they're going to be told, oh, well, I don't believe anybody's going to be told off at A&E. And if you think you've got a child particularly who isn't well, you would be daft not to go to the place that it's seen. Yeah, no, I don't. We're getting worse instead of better. I'm sorry. You know, for the professionals, it might be really good. This thing, when it isn't good, it's like the day before yesterday, when somebody I know had a GP call book for 10:30 or 10:20. They had to do a time because she works in a school. They didn't come, they didn't ring her at the time that was said or any of the other time during the day. And they had, it turned into a row in the evening. And, we've forgotten customer care, as far as I'm concerned. And I've been lucky with an awful lot of the things that have gone on during COVID and my care. But people aren't happy. And just thinking that they will be happy ain't going to work.
Yeah, I think the point, Alicia, is that actually we're relying on people using everyone using technology, and I think we've got to remember that actually not everyone can use that technology basically. So right, I'm going to move on to Councillor Kingston. The next one I saw indicates.
Thank you, Councillor Blackburn. So my first, I've got two parts to it. One, I'll just briefly mention that I use the rheumatology clinic, so I was aware of those changes, and I had to use the change system during the last 2 weeks, and my experience was it actually works reasonably well. So thank you very much, Lisa, for the changes. For the changes that have been made? Sorry, Penny, for the changes that have been made there. I think I've got my names wrong there. I apologise. I'm sorry. So that's that. The question I had was about when someone's referred through their GP, then you've instituted a meeting and you described it as a job planned clinic. And that was when I got lost, because I've no idea what a job planned clinic is. So if you could tell me what a job planned clinic is, please, I would appreciate that.
The difference is, the reason I said job plan clinic was I wanted to distinguish between it being advice and guidance. So what we have done is the GP will refer into the hospital. So they would usually refer into a clinic, and the patient will be booked into a clinic. We have set the clinical assessment service up as clinics. So they are listed clinics and we book patients into them, but the patient's not present. But it means that that consultant has that clinic in their diary as a clinic commitment, where they will sit down and they will do those reviews. The only difference is the patient's not there. So they have that dedicated time to do that, so that is protected time, just as a clinic would be. It's not an advice and guidance where...
Sorry, I think we're having some feedback on this.
Can somebody mute Farzana? I think it's Farzana's thing that's causing the feedback.
I think it is. I think she was having technical difficulties, so our apologies.
Yeah, sorry, I'm having technical difficulties.
That's better.
This is reminding me of when I went clubbing in the 90s.
Sorry, Lisa, if you continue. Yeah, I think you
it's okay. That's just made me laugh.
The 1980s, maybe.
You're taking me back now. What would happen is that they would do a full review of that patient's referral and case notes, and then they would either write a letter to the GP, or they would contact the GP, or the clinical coordinator, the class coordinator will get in touch with that patient and say, this is the next step for you. I'm going to book you a scan, and your scan is booked on X day. So they're still getting that feedback, and their pathway is being coordinated. It's just that they're not there for that first appointment. Other than that, it runs exactly like a clinic. Does that make sense?
Yeah. So, Councillor Barnes.
Thank you, Chair. Thank you, Lisa, for that report. Very comprehensive, and I think what is indicative of that is that we're on a journey. And that journey isn't complete yet. So I think it would be useful to come back at a later point so that we can review where you've got to, how you've performed over that time. So I think it's a very difficult one. I think the one thing that I would flag up is, and this was a point that was raised at the previous meeting, was there was that gap when the hospital stopped doing appointments and things were being missed in the appointment system, or patients weren't aware of what was going on. And this does go back a bit, where the GPs were making a referral, but because there was no outpatients being seen, things did seem to get caught, and this might be what Councillor Swift is also referring to. Things seem to get caught and missed. I mean, how has the system developed so that if this happens again, that won't happen again?
So we've just been working with a third-party provider now, and Emily, am I right in saying from January?
Yes, from January, yeah.
So from January next year, patients who are on the waiting list, so the follow-up patients that I referred to, will be getting letters, and we'll be doing regular contact with them. Want to make contact to have a touch point, to say, how are you? Has your situation changed? How's your condition now? So one's to do that touch point of let's take an assessment of where you are, but also to let patients know that we want to be in contact with them, how to get in touch with us if they need to, and to know that they're not forgotten in the system, because they're not. We're trying to work as hard as we can to create the capacity to see as many people as we can. So we need to be having that communication, and we want to start that communication and make sure that all our patients are communicated with. So that starts in January.
I think we've also done quite a lot of work with our reporting team just to ensure that we have no gaps in our reporting of e-referral, and ensuring that all GPs are reviewing via e-referral. Referring in via e-referral is really important as well. So we've had those conversations with CCGs and ensured that that is the case.
Excellent. Thank you, Emily, and thank you, Lisa, for that. Councillor Parsons-Hulse, please.
Thank you, Chair, and thank you, Lisa, for this really in-depth report. It is great to hear that there's so much going on in the background, and very often, obviously, we don't see that. So that's great. And so, I mean, similar to how other people have experienced these appointment systems during lockdown, I'd just like to share a personal experience, if that's okay.
Only very quickly. We don't really. We've not really got time for huge amounts of personal experience. I'm not going to go into a big story about it, but I nearly ended up with spinal surgery on the back of not having an appointment, and it was really confusing. You know, I ended up in A&E, and within minutes it was like, right, okay, we need to blue light you. 10 years ago, I was given a physio appointment, and it was dealt with straight away. I've got 2 herniated discs. So yeah, spinal surgery is obviously very expensive for the NHS, and something I want to completely avoid, as you can understand. And then the care after that was quite challenging. For me, I don't understand how you can do hands-on physio through a video link. And then when I was actually given sheets of paper and asked if I had a husband who could do this, I mean, that's like giving instructions to your car garage person and saying, oh, can you change the oil filter on this? You know, I mean, my husband's an engineer. He's like, I can't, I didn't train in physio. So I think there's something about, it's great that we're giving advice and guidance and stuff online, but when somebody actually needs hands-on treatment, I would really like that to be embedded into the system. I've also had conversations with other people that this has happened to, but I don't want to disclose other people's experiences. So I'm talking from a personal experience, but there are many people with spinal injury right now who are struggling. Now, I've lost sensation in both my legs. So that's how serious it is, and hopefully I will be able to avoid spinal surgery. But I really do think when you're kicked out of the system, and the consultant said to me, I've got to sign you off. I mean, I understand for figures, you've got to be signed off, fair enough. But if you need to see that person again, as you pointed out, you need to have a point of contact, to go back through the whole system and wait for another 6 months when I've got a potential spinal surgery looming. That is far too anxiety provoking, shall we say. So yeah, just a little bit of feedback. Thank you so much, and thank you, Chair. No problems at all. I'm sure it's duly noticed, and we will see improvements. So Councillor Hutchinson, I've got you next.
Yeah, thank you, Chair. It does sound as if there's a huge amount of work going on, and booking outpatient clinics is very much one of the dark arts. But I would guess that what you were talking about, patient-initiated follow-ups, which I really applaud, would fit what Councillor Parsons-Hulse is needing. The clinical assessment service, has tended to mean in different places a third party reviewing GP referrals and saying, oh, computer says no, and bouncing them back to the GP. I'm really pleased to hear, I'm correct, am I, that this is being done in-house and will remain in-house?
Absolutely.
Great. My third question is about complaints from GPs in the media, that they are overloaded by patients who've been referred from secondary care, from hospital, back to the GP for investigations and for prescribing. Now, how has that been an issue here? And if not, how have you prevented that from happening?
It's not been an issue as in complaints being raised, but it is an issue that has come up at our Outpatient Transformation Board. And last month we had an in-depth conversation with our GP partners that are there. So we have the LMCs and we have the GP CCG leads on our board. And what we are going to do is trial in 2 specialties how we can help each other out. So what we're saying to GPs is we need you to improve on the way that patients are referred and that full data set, and make sure that's coming through, because that then creates us some capacity where we don't have to start chasing things. What can we do for you? That you know, if you've got a trade-off of we can help you out, how can we help you out? And that did come up about prescribing and not referring back for investigations. So in 2 specialties, we've just set a meeting up now to look at a pilot in each one to say, can we run some pathways differently where we prescribe and we do those investigations that we would have naturally just said, go back to GP to do. It will save the patient time because the patient's not going to and fro, and it saves the GP time and has a knock-on effect for us as well. So we're piloting it, Colin. Hopefully it will work, and if it does, we will be looking to roll that out across other specialties.
Good luck, and if it does work, hopefully broadcast it more widely than just in Calderdale.
Excellent, thank you, Lisa.
Chair, sorry to interrupt. Something urgent's cropped up on personally, which I'm going to have to drop out of the meeting. If I get it resolved, I'll be back. Okay,
no, that's fine.
So I'm going to have to drop out for about 10-15 minutes. All right, sorry about that.
No problems, good luck.
Apologies, everyone.
Yeah, take care. Councillor Benton.
Thank you, Howard. It's just a question really regarding the new system about when the clinicians review a patient's information and they decide that a patient can be seen face-to-face or virtually, and if they say virtually, can the patient insist they want to see the clinicians face-to-face? And if they could, or they couldn't, how long would this delay?
So we have, just to be clear, we have not switched off face-to-face, and if a patient wants to have a face-to-face appointment, we will always honour that. Seeing a patient, we have virtual clinics that are set up. Emily might be able to answer this better than I can, but we have virtual clinics that are set up. Some clinicians do a mix. So they might be sat in a clinic room and see some patients face-to-face while they're doing some virtually. And we have some clinics that are just virtually or face-to-face. It's dependent on the clinician and the demand, really, and we flex that. It shouldn't increase their waiting times at all if they need a face-to-face or a virtual, because the capacity is the capacity. So if a consultant sat in a clinic room and they're doing some face-to-face and some virtual, they would just be put into any of those slots.
Thank you, Lisa. Emily, do you want to follow up on that? Do you have anything else to?
No, I think that's well answered by Lisa, to be honest.
Yeah, no, thanks, thank you. Sorry for the wait, Councillor Durrans. It's finally Councillor Durrans, please.
No, don't apologise. Thank you, Chair. Again, I'll offer some personal insight, but without much kind of time. I have shared care with my GP, and I've got some care from a neighbouring trust and some from Halifax, and I have to say, throughout the pandemic, it has been fantastic. I've not noticed a lack. The first thing was on the back of Councillor Benton's. Again, when appointments come back to face-to-face, for me personally, I prefer telephone appointments, and I know a lot of others do. Will there still be an option of both? In order that, you know, if you've got other responsibilities or travel time. And the second one is, and again, it's around that first appointment. I'm sorry, I can't remember the name of it, where just the consultant's there. So as I just said, I've got shared care. I've also got really good relationships with all my consultants, and I have specialist nurses. I'm quite confident in taking forward that I can contact them when I need to. Would I have felt like that 8 years ago when I was scared, and any delay in me seeing a professional? I think that would have created quite a lot of anxiety. And I'm wondering what the delay is in that appointment being held and the person feeling confident in what information they're given or what steps are being taken and being fed back with that. Because I think the people that have been long-standing patients, we've already got the relationships with our consultants. So a telephone appointment or an online appointment is very much about that relationship that's being built, but it's not necessarily the same at the beginning of the journey.
Thank you, Lisa.
Let me just describe two different pathways there. So you've got that first appointment. So when we talk about the clinical assessment service, that's the first interface with us. Some of that's about how the GP explains a process to you. So we've done a lot of comms with GPs around, it's not an expectation of those services that you would have that first appointment, what it would be. And it's about managing expectations, because if you think that you are being referred for an appointment and you don't get an appointment, that creates a level of anxiety for people. It would me. But if we prepare people appropriately to say, actually, we're referring you to the service to see what the next steps are, that's a different expectation. And I was talking to one of our gastroenterologists that has been running that service for 2 years now in gastro. And he has had feedback from, he said, 3 patients in the last 2 years around any anxiety. And when he's talked through it with them, that they've understood. But it's been about how they've been prepared for it. So if we do pick any of that up, we will be picking up the comms on that around how we prepare people. On the patient-initiated follow-up, where you are put onto a pathway where it's for you to contact the service when you need it, there is a criteria for that. And I think one of the minimum criteria is that you've been on a pathway for you've been under that consultant for 2 years, so that you have built that relationship up and you are confident and they are confident clinically as well, because this is a big step for clinicians around letting go. And that has taken a lot of moving people's mindsets clinically to do that, because they're taking a leap of faith as well. So you've got to have that relationship in place, and you've got to be confident that people will contact the service when they need it and not sit there wondering what they're going to be doing. So we do a lot of education as well around what services you need to contact at what time, depending on the speciality. Does that help?
Excellent. Thank you, Lisa. I think it's really helps. It's filled me with a little bit more confident than, you know, certainly 2 years ago when I was really a little bit concerned in the feedback that we were getting. I think it's very much going in the right direction, and very much welcome you back to the scrutiny at some stage with progress as to and where we can help as well. So very much appreciate you attending and the presentation and very useful information as well. So and taking our points on board. So thank you very much for that.
Thank you very much.
No worries at all. So item number 7 is age-friendly Calderdale. We do have Ken Barnsley. We've had the report. So do you have anything further to add to the report?
Hi, thanks very much, Chair. Ken Barnsley, I'm Acting Consultant in Public Health in the Public Health Department. I just wanted to say a little bit about the report that was circulated. That's the Cabinet report that was approved by Cabinet on the 4th of October with the recommendation to full council that full council approves that we seek membership of the UK Network for Age-Friendly Communities, that as a council we sign up to the Healthy Ageing Consensus Statement, and that we also encourage all of our partners to sign up to that Healthy Ageing Consensus Statement as well. Just wanted to say a little bit about that. I mean, obviously you've had a chance to read the report, but I guess one of the things to think about is what age-friendly and age-friendly Calderdale might mean. So the point that we're at in this process now is that we've declared a commitment for Calderdale to be age-friendly. And that commitment then needs to be put into action. So the International Age-Friendly Network was something that was established by the World Health Organization almost 20 odd years ago now. And it's an evidence-based approach really to improve the lives of older people and create places that are really good places for people to get older in. So it's an international network now. There's more than 40 members across England, Scotland, Wales and Northern Ireland, from Torbay to Sunderland, Brighton to Glasgow. Manchester was one of the first cities to sign up to this, and they've been working on it for almost 20 years now. So we're embarking on that path and really wanting to understand what it means to be age-friendly and what it means to make Calderdale age-friendly. And in addition, we're wanting to encourage us and our partners to sign up to that Healthy Ageing Consensus, which was developed by Public Health England and by the Centre for Ageing Better. And that's got 5 key principles, which are all about putting prevention first, removing barriers, ensuring good homes, narrowing inequalities. And particularly, I think, a really important one, which is all about challenging ageist, negative cultures and practices. And it's about the images of older people that we as a council and that we as a place put forward. And I think that's a really important thing about challenging some of those images. And we quite often see when we're as an organisation putting forward images, it's always about younger people, and we need to have some really positive images of older people. Because I guess one of the things that we have to think about is the World Health Organization's definition of older is 50 plus. So I'm sure that covers quite a lot of people in this meeting, certainly covers me. But if we think that, and I know for a fact that there is a person in our borough who's aged 101. So we've got more than 50 years of age, experience, talent and expertise in our borough to draw from. That's more than, probably more than 50,000 people, very, very diverse group, and all sorts of different people experience age differently. So I think those images and that ageist culture and practice is really, really important.
Good, excellent. I think we've got some questions. I think we'll go to the questions, and if nothing's picked up, I know we're looking at this in terms of the Big House Town Investment Fund and looking towards implementing these principles. I think it's really important that we do so. We are facing an ageing population, so it is extremely important. So I've got Councillor Megan Swift first of all.
Yeah, a very, very quick one. Going back about 8 to 9 years, we were going to become a child-friendly borough. Leeds had already started this, and they went from strength to strength. And I don't say that about Leeds often, but it was really good. You know, we've suddenly, somewhere, it's dropped off scale. It's gone from being something that everybody, when they wrote a report, was taking into account, and it's got lost. So I have to ask, is this one going to get lost in a few months or a couple of years? because, you know, I fought for a long time, and I don't know where Ian's gone, but he's gone somewhere, that, you know, we have to remember older people are as important as children. And sometimes it didn't show up, but children still matter as well. So good luck with it. If you can get it to work properly, it will be fantastic.
Good. I think he's going to respond to that. I think he's got his hand up, so I'm presuming he wants to come back on that.
I hope that Scrutiny, current members of Scrutiny and future Scrutiny members who may not have even thought about standing for election in years to come will hold us to account over being age friendly. We know that our population will grow old, but what we need to do is make sure that as we make planning decisions about transport, about infrastructure, about how we make our homes accessible for older people so they don't have to move out of home because they may be physically becoming less mobile, those are things that I think we should be held to account on. I think it's sometimes really easy to think that this is a fad, but actually the capital that older people, both financially, experience-wise, and just breadth of knowledge, we need to be able to utilise, and we need to be able to ensure that we make most of it. So I'd set the challenge for Scrutiny really, which is let's not make it a fad. Hold us to account to make sure we deliver on it. And as somebody that now is well into the older people's categories, because I just passed my 60th birthday, I think I've got a bit of vested interest. So I'm really keen that we don't see this as just a fad.
Excellent, thank you for that. Councillor Hutchinson.
Yeah, kind of on the same theme. I mean, I see the age-friendly cities framework as not being good so simply for the elderly, but actually for everybody. Think pavements that are safe and easy to navigate, combating digital exclusion and accessible information and access to health services, I think are good right across the board. But things like public health, social care and climate change span the administrative compartments of the council. So how do we ensure that new policies that are introduced, say through highways, are consistent with the objectives in those 8 domains?
Indeed, I'm going to bring Councillor Fenton Glynn in on this. He's raising his hand as though he's going to answer it.
Yeah, I mean, I think I said at Health and Wellbeing Board the other day, the job of this policy is not simply to sit in my directorate as much as I like keeping control of everything. The job of this policy is to spread itself throughout the council like cheap perfume. And I think by saying that, what I mean is that actually to be effective, we need to look at everything that we do and make sure that we are friendly and inclusive to older people. And that doesn't just mean, you know, the kind of tea dances and bingo. It means understanding that ageing is changing and that people have different needs. And going back to Councillor Swift's question, one of the ways we're going to be kept accountable is that there's going to be a consultative body that we're going to keep going back to, who will hold me to account as well. So that has to be done, and we have to make sure that that's done well. The other thing I'd say is that we need to think about the changing nature of ageing. I completed a marathon on Sunday, and the person who was a little bit further ahead of me than I'd have liked was wearing a V65 vest. So they were over 65 years old, and she was quite considerably ahead of me. So, you know, I think aging is changing, and actually for us to be successful, we both have, you know, we don't have to see aging as about deterioration. We need to see aging as thriving. And so that's part of our job, is to make it somewhere that you can, and that, you know, be that in our spatial infrastructure, be that in our digital inclusion, or be that in our employment practices. But yeah, I'd go back to that kind of consultative body you're going to hold us to account. When I worked on welfare rights, we used to often go back to that that phrase that's often used in the disabled community, that nothing about us without us is for us, and that's going to be really key to making sure that I am listening and doing what I can. And I say that as one of the people that doesn't have to declare an interest at the moment.
Thank you, Councillor Fenton-Glynn. Did you want to add something else? Do you still wish to keep your hand? No, that's fine. Councillor Durans, please.
Thank you, Chair. Like Councillor Hutchinson said, I think it can definitely spread out because it's based on the social model, and that's inclusivity for all, not necessarily just when you're aging. As somebody with a disability, there was lots of points in there that I obviously would appreciate have been considered. Just in section 11, or point 11, sorry, in the inclusive section of breakdown, there's a couple of points. First of all, in the gender, we're only considering that we're breaking down on the pay gap. Now, I don't know if we do have a literature on this, but we're only looking at the gender pay gap between male and female, and I don't know if we do have any other literature, but whether it could be worth considering, thinking about the data as we move throughout society and time. Secondly, sexual orientation and LGBTQ+. Again, sexual orientation and gender identity are different characteristics. And thirdly, we haven't got neurodiverse conditions. We've got learning disability, but not everybody with a learning disability has who's neurodiverse or a mental disability, has a learning disability. Sorry, I'm getting all my words confused. So we've got physical and we've got learning disabilities, but there are groups of people that are missed that might need some support, that might be worth considering, and obviously they need to be recognised within those groups. So that's it really from me. I hope that's okay to bring you up.
Yeah, Ken, do you want to come back on that? Thank you, Councillor Durans.
Yeah, thanks very much, Councillor Durans. Those are really important questions, and we'll be doing a much more detailed equality impact assessment as we progress along. So those are really important points that you raise, and we'll kind of take those on board as we go into that equality impact assessment.
Excellent, thank you. Councillor Barnes.
First, apologies for having to drop out, and I did miss the first bit. But second, it's good to see that Councillor Fenton-Glynn wears cheap perfume. I've always wondered, and now that's been confirmed, and it is on YouTube, being streamed live, so we have evidence of that. Third, unlike Ian Baines, I am a member of the ageing population, being the better side of 50. Just a couple of things, and this is my soapbox on reports. I'm sorry to get back to this, and I think there are two facets of a report that should be readable to people who don't know, i.e., somebody who isn't involved as we are, and I think this one fits that one. The second is, and maybe this is something Howard we need to pick up with internally, is that when I see a report which has time dates on it, and particularly dates in the past, would be nice to have an update and an idea, a red, amber, green, or an idea of where we are in relation to those. Because if I look at the report, age-friendly baseline review, August to September, and it is just nice, and it makes it easy and visible for people to see where we are in relation to those timeframes, either they've been completed or we're on track. So I think it's just something that we perhaps, Howard, Councillor Bagger, need to pick up at a later point for when people prepare these reports. But finally, I think this is the same thing that happened with in previous considerations within the council, is this needs to be a facet within the decision-making process. In the same way that we looked at gender equality, the same way we've looked at equality of an exclusion within council policies. This, to me, needs to be embedded within that process. So when people are making decisions, making reports into cabinet to make recommendations, this is part and parcel of that, because that's the way in which to embed it across all aspects of the council and not just sitting within the scrutiny committee. Thank you, Chair.
Yeah, no, good points raised. Yeah, on that one, I think, and then we'll take those on board as well. I think on an internal. Councillor Fenton-Glynn.
Yeah, just to come back very quickly on a couple of those. I said like cheap perfume. I didn't say like I use cheap perfume. No, more seriously, Danielle's point is very well taken. And I think, you know, particularly we need to think also about, I think there are some different communities that treat aging in a different way as well. So, you know, if you look at the Asian community in Halifax, then aging in that community may be very different than aging in the community in Brighouse or Hebden Bridge and so forth. With the specific LGBT community question, I mean, I think Ken's already been in touch, but there are some very good community organisations like Friends of Dorothy in Hebden Bridge for the for the older lesbian community. And actually, you know, the more we can do to make sure that we're linking up with people who are already doing good work is good. And Councillor Barnes's point, I do think we should consider the ageing community in everything we do. What I would warn against is I don't want it to feel a bit like the equality impact assessment. So when I used to work for a trade union, we used to see like every report and consultation into getting rid of a load of your staff would always say, we've considered the equality impact assessment and we think it's probably fine, as they got rid of a load of people who often fell into a certain protected characteristic or other. And I don't want it to become a tick box, which is why actually I think part of the ongoing monitoring isn't just about making sure that we get an officer to tick a box there. I think it's also about making sure that we talk to the community impacted. And I think that's where, you know, the kind of ongoing consultation is perhaps more pertinent than just doing an impact assessment and thinking of the older community and everything we do. Not that I'm saying that that's necessarily a bad thing, but I think that it's, you know, it's learning from lived experience is probably the strongest way forward.
Okay, thank you for that. Councillor Kingston.
Just following on from that about the including it in everything that we do, all our decision making. I'm just gathering from, I'm learning because I'm a new councillor, and I attended the equality and diversity training session last week. And what I got from that was, I understand that age is a protected characteristic. So it should already be part of our decision making as a protected characteristic. Am I misunderstanding that?
I think it's, if I can come back on that, I think it's really emphasising when we're looking at future things, like we're looking at things to improve Brighouse Town Centre with £19.1 million. So it's making sure that actually it's the key. Actually, is it going to be age friendly in 10 years' time? I think that's part of the key elements. Yes, it has been something that we've looked at, but not as a real important issue. You know, it's been an add-on rather than you know, actually this is a consideration. Is it going to last 10 years? Is it going to last 20 years? You know, for the ageing population, really, I think.
Yeah, no, it's great. I mean, I'm really behind the intention of the age-friendly plan. Yeah, great. Thank you very much.
Excellent. Right. Okay. I've got nobody else indicating to speak. So thank you for reporting on that item. We'll go on to item number 8, which is a COVID report 12 months on. I'm going to challenge you, Ken, to 10 minutes at the max, because we will have some questions. It's been an extremely useful session, but as you can imagine, it's getting on, and we will getting a little bit more weary. But so over you to Ken. Thank you for coming as well, by the way.
Yeah, thanks very much, Chair. The Director of Public Health is engaged in the Facebook Live at the moment. She's chairing that session, really important one in relation to COVID. So in terms of the current situation in terms of COVID, last week we've got the highest rate that we've ever had during the whole of the pandemic. And at the time we started bringing in additional advice to schools, we had the 7th highest case rate of any English upper tier local authority. It's now gone down to 19. But the rates within the borough are very, very high, and that's placing significant pressures on our health services as well in terms of the hospital services. And what we've identified, and it's fairly clear that very, very high case rate is driven by transmission in schools, and it's in school-aged children, and that rate has never been as high as it's been in the most recent weeks. What we do know, though, is that the vaccine weakens the link between those high numbers of cases and serious illness, but it hasn't broken it altogether. And what we've also got coming through that, and we've seen this in previous phases of the pandemic, is that we have very, very high rates in young people, and then it kind of sweeps upwards through the age groups. And we've currently got one of the highest rates of cases in people aged over 60. And as we know from previous phases of the pandemic, it's those groups that are the biggest predictor of need for hospital care. So we're now seeing increasing numbers of people needing hospital care and more people becoming seriously ill as a result. So as a result of this, the kind of the key policy update really, contact tracing shows that the vast majority of people in Calderdale with the virus are coming into contact either through school or at home. So it's household transmission. So generally children at school, and then it's transmitted into the household. So we've got large numbers of health and care staff off work, either with COVID themselves or because they're looking after children who've got it and they're a direct contact. This is limiting the ability of our NHS and care services. So what we want to do is to try and reduce that transmission in schools, try and get it under control, to give us time to vaccinate older people and those who are clinically vulnerable. And this has kind of been the feature throughout the whole of the pandemic. We've always focused on the first phases of vaccination, on the older and more vulnerable, and we've worked our way down the age groups. And that's the same now in terms of making sure that everybody's doubly vaccinated, and in the strategy for getting the boosters started, starting with the clinically vulnerable. So should we have acted sooner in terms of schools? Well, the national rules about COVID cases were introduced in September, and those have had a major impact because they've changed the way that we look at outbreaks in schools. And perhaps it's been that we haven't been able to act quite as quickly as we'd hoped to do. So as a result, I think, Chair, we're bringing in some additional measures. So we work very, very closely with the DFE and with head teachers. So following discussions with the schools, we wrote to all schools and parents last week, asking them to consider extra measures over and above those that are involved in the national recommendations. So we're asking that anyone who's got COVID will know how hard work it is to prevent it spreading with other family members. So first of all, we're asking that when somebody in the home has tested positive for COVID, any children and young people that live with them stay away from school for 3 to 5 days, and then they get a PCR test. If the PCR test is negative, the child returns to school, but they must stay home and arrange the test if the symptoms persist. So these are the additional measures. We're also asking parents who still want their child to continue to attend school, have the right for them to do that. So all of these new measures are being introduced, Chair, to limit that transmission in younger people, which, as we know, sweeps up across the age groups and drives the impacts that we're starting to see on our health and care system. We know that currently there's more than 90 people in the hospital trust with COVID, and some of those are, I think there's 7 now in ICU. So that's all driving that. So the measures we introduced are to reduce that spread amongst that population and try and reduce it sweeping upwards, because our case rates are as high as they've ever been. I think I'll leave it at that, Chair, and obviously I'll take any points. I've got thank you. Yeah, no, thank you for the update. 5 minutes as well, Chair. So
I'm impressed, very impressed. Well done. You know what I'm like then in that case. Councillor Hutchinson.
Thanks, Chair. We know from previously that for 1 in 4, 1 in 5 cases of COVID were contracted in healthcare settings. And we know that that also had a fairly disastrous effect, overflow into care homes. And once that became apparent, measures were taken here to have isolation facilities outside of care homes, because a lot of care homes can't actually provide, aren't able to provide that within their own premises. Is there what is the situation within our care homes? And is any consideration being given to those kind of measures.
Ian's going to answer that one.
So Councillor Hutchinson's right to identify that that social care, particularly residential and nursing homes, were at the forefront of the pandemic from the outset. I think one of the things that I am particularly proud of that we did in Calderdale is we established 3 independent facilities outside of an existing care facility so that we could establish CQC regulated services for people who may have become contacts of someone who resides in care who might be a contact of somebody who was positive, but also where the person was positive and the home didn't feel they could support that person in isolation until they became well again. So we very early on established 3 different facilities that were key to our approach, and I think actually did contribute to our lower number of care home deaths than other authorities. There then was a national directive to establish something called designated beds. There was a national directive and we were able to establish that. We have continued to have in contract provision a smaller number of beds outside of former residential units. So for example, we've used a site that's got a standalone unit away from the main care home, and we continue to use that today. And we are able to step up some additional facilities if required. Just in terms of where we are in current care home outbreak, so we've had a really good response for both staff and residents who have been double vaccinated. And again, that's contributed to our ability to keep resilience. But we currently have 3 outbreaks in care settings, 2 in residential units and 1 in supported living accommodation. And I think it speaks to the point that Kenneth was making earlier, which is what we know about the vaccination programme. It doesn't stop you getting the virus, but it breaks the chain in terms of more acute illness, and we are seeing that still stand. And we have also started the booster campaign in terms of residential residents.
Thank you, Ian, for that. The updates. Councillor Barnes.
Thank you, Chair. Actually, I have 2 questions. I had one before Ken did his report, which was in relation to vaccinations of care home staff. Where are we on that? And in particular, is that having an impact upon staffing within care homes within Calderdale? But the second one, which is really come out through Ken's report, where he said that the main transitions was school and homes. Is this not more apt now to have us reconfigure the booster campaign and actually aim it more at that? So in particular, let's say for teachers and obviously in relation to care staff, because if our main transmission is through school and home, then it's that age group that is most affected. And it surely is that age group we should be actually prioritising the boosters for. So I wonder what the thoughts are on that.
Ken, do you want to come back on that? Yes, you
do.
do.
Yeah, I mean, the programme of the approach for the booster is a national programme, and I think the idea is that we would seek to provide boosters for those people who are most vulnerable, as we did previously. So it's not to prevent transmission necessarily; it's to ensure that if people do get COVID, the impact of the disease on them is reduced. And that's what the evidence has shown. I mean, I think the evidence shows that for two lots of the vaccine, the chance that you will get symptoms is reduced by 96%. So, you know, the vaccines are very, very effective. And I think it's the same logic. So it's all about reducing significant illness and therefore reducing the impacts of people who are likely to go into hospital and need that really intensive care and support, rather than necessarily having a direct impact on transmission.
So in other words, what the policy is we're quite happy for transmission rates to be high. because effectively that's the policy at this moment in time, is it not?
I'm not sure that we're particularly happy that for transmission rates to be high, but I think the national regulations, which remove most of the restrictions on our public, do have that effect, I think.
Thank you for that, Ken.
Thank you. Ian, do you want to come back on that as well? You've got your hand up on.
Thank you, Chair. I think there was another question inside Councillor Barnes's.
Yes, it was the vaccination and care homes staff and how that's affecting care homes. Is it impacting upon the staff ratios? Yeah.
Yeah. So as most members of Scrutiny will know, government introduced the concept of mandatory vaccinations in residential care homes for all CQC regulated services. That's for older people and people with learning disabilities. And once that statement was announced, and the process was that by the 11th of November, all care home staff needed to be double vaccinated. There was a critical date of the 16th of September, which meant in order for someone to have delivered their second dose by the 11th of November, they needed to have their first dose by the 16th. So we started doing some monitoring and working with our providers to understand what the risk in terms of losing people from the care sector was. And when it was first announced, we thought we might lose up to 130 staff who, for whatever reason, weren't comfortable or able to take the vaccination. We now know that that figure is around 32, which is a smaller number, but actually when you're looking at an 8% vacancy rate overall and a sector that's struggling to recruit staff, that adds a challenge. So I think we are seeing an impact of that. So some people will be or will have already left the sector. It may also be a determining factor about future recruits who may not want to be vaccinated, so therefore won't consider a job in social care. So it is a factor, but a much more smaller number than we'd originally assumed in our initial analysis.
Thank you, and I think it's something that potential on our work programme in relation to the workforce issue and general. Councillor Fenton Glynn.
Yeah, just kind of coming back on a couple of those. I think I think the pace at which we managed to get care home staff vaccinated was nothing short of remarkable, and it's really a credit to the team and all of the providers that we worked with that we got that done. I take Mike's point about, Councillor Barnes's point about vaccinating the booster shots to care staff. I think in terms of the boosters for them, I'm not sure that many of them, just because of the general age of care staff, have had the clear 6 months, which obviously is what you need for that to have an impact. I think what is a strong point is the prioritisation, particularly around teachers. And this is, obviously we have to be guided by the government guidelines. I hope that we will learn from what we did before when we kind of were able to flex a bit with some of the kind of spare vaccine doses and kind of prioritise people who kind of were encouraged to apply for them. So I hope that we'll do that, but obviously that's not necessarily within our gift, because obviously we are governed by that. What I would add to that, though, is that actually we are doing, I think, a fairly good job now that we've started, and Councillor Wilkinson isn't here to follow up on it, but on vaccinating children in schools. And I think that plus some kind of increased social distancing and mask wearing measures in schools that we're kind of pushing on as a local authority should hopefully help. But we're in a system where, unfortunately, some of the kind of what I would consider to be the common sense easy regulations were kind of dropped, and I think that's made all local authorities' jobs difficult, and we're seeing that expressed in what's happening in Calderdale.
Thank you for that. Right, nobody else has indicated to speak, so I'd like to thank Ken for coming on the last two items. Hope we've given you enough airtime. I'm sorry if you feel we've cut you short. So my apologies. We never like to cut anyone short. Apart from Mike, the next item on the agenda. So we go to the work programme, which has been circulated. Mike thinks he's got two minutes. He's got 30 seconds to add two extra points. So Mike, my lodge.
As quickly as I can, we've got too much on the agenda for the next meeting, and I'll talk to Councillor Bragger about reducing the number of items on it. I've got 4 points actually. Secondly, the main item tomorrow, next month, sorry, is I think the community services item that the NHS are coming for, and that feeds into the work of the Calderdale and Kirklees Joint Health Scrutiny Committee. So that was probably quite a substantial item. Good news, we will take at least one item off, which is the ethical care charter. I've had a conversation with Ian and we're going to do that later in the programme, if that's okay with the board. And finally, Councillor Blackburn and Councillor Barnes had, I thought, a very useful meeting with the local medical committee earlier this week. And the outcome of that meeting is to see if we can arrange an informal seminar for members of this board to talk about issues about access to general practice, which I know has concerned a number of you and you've raised again this evening. I think that was 2 minutes, Chair.
It was less than, so I'm always impressed. So thank you ever so much for that. Yeah, it was an extremely useful meeting. So I think that concludes the items on the agenda for this evening. So thank you every member for contributions and for attending, and thank you officers for your equal valuable contributions as well. So have a nice rest of the evening. Thank you very much indeed.
Can I just say, members, because of our technical difficulties, I think we're going to have to close down the live stream by closing down the meeting. So if everyone could leave as quickly as they could, then we can get the live stream off.
That's fine by me. Thank you ever so much. Have a nice evening. Take care.
Good
Thank you.
All right. Thank you, Chair.
Thanks very much, all.
Thank you.
Still seem to have Councillor Swift.
I've just thrown her out, I think. Okay, Fazana, let's shut it down and see if it works.